Okay, guys, so 3 diseases. Let's go back, sit down, guys. Oh. Relax and chillax, enjoy. Okay, so 3 conditions: hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency. Okay. Now, in hemochromatosis, there's abnormal iron metabolism. How? Well, there's increased iron absorption. Okay, so the underlying cause is increased iron absorption. Okay, so there's increased iron absorption. That's the basis of it. Too much iron absorption, especially where? From the duodenum. Okay, so this is a GI defect in the sense that there's the iron transporter in the GI seems to be hyperactive. Okay. Wilson's disease. Wilson's disease is copper overload, so it's a copper transporter. Defective copper transporter. It's also known as copper ATPase. Know that it's active transport, copper ATPase. So I'll just put in the bracket ATPase. Alpha-1 antitrypsin is deficient, so antitrypsin is antiprotease, right? What is trypsin? Enzyme. It's a protease enzyme. Antitrypsin is protease inhibitor. It's a trypsin inhibitor. Antitrypsin is trypsin inhibitor. Good? Antitrypsin is trypsin inhibitor. Okay? So we don't have that trypsin inhibitor anymore. That's all. Very nice. Now, in hemochromatosis, most of it is genetic. It's one of the most common genetic disease of Caucasian, especially number 1, genetic disease of liver in Caucasians. Hemochromatosis is the most common hepatic genetic disease of Caucasian people. Okay. So, if it is genetic, that means what chromosome is involved? Chromosome 6. Very good, very good. Okay. Chromosome 6. How is it inherited? Autosomal recessive. Excellent. So chromosome 6, autosomal recessive. Good. And the gene is known as hemochromatosis iron gene. No, that's not. HFE. Yeah, FE stands as a symbol, right? Those of you, I know you guys don't like periodic table, but I don't like it too, so FE is a symbol for iron. But anyways, iron gene. Just say iron gene. Okay. Wilson's disease. In Wilson's disease, again, it's a genetic disease. Which chromosome is involved? Excellent. Chromosome 13. What letter is M alphabetically? What number is M? 13. W is upside down M. So maybe if you want to remember it. Weird stuff. Antitrypsin is also a genetic disease. Which chromosome is involved? We keep increasing chromosome. 14. Good job. 14. Okay. All right. Wilson is also autosomal recessive, right? Antitrypsin is also, all of these are autosomal recessive diseases. Okay, now, at the end of the day, so in hemochromatosis, we have iron overload. Iron overload. In Wilson's disease, what do we have? Copper overload. In antitrypsin, what do we have? protease overload. You can think of it that way, sure. So that means protease activity is not suppressed. It's super excited. So let's talk about some of these proteases. Which protease are we talking about? Hepatic protease? No. We're talking plasma protease. Antitrypsin is only produced by hepatocytes. Okay, especially neutrophils have a protease known as elastase. Neutrophil also have trypsin, which is not pancreatic trypsin, which is neutrophilic trypsin, right? So we're talking about inflammatory protease. It's the inflammatory protease that are causing the problems now. Yes, sir. Yeah. Very good question. Very good question. Very good question. Now, each chromosome have how many genes on them? Many genes. Many genes. On chromosome 13, you have many genes. If it's trisomy 13, then it's called patal. But if it's just one gene mutated, then it's specific disease then, depending which one. Okay? In this case, in Wilson disease, it's just the copper locus, copper transporter locus or location is that's defective, mutated, not the entire chromosome. Good? Yeah. Yeah, chromosome 13 is involved in different, even in some leukemias. Okay? Alright. Okay, so iron overload. Now, we have to approach these. When you have iron overload, it can deposit where? Anywhere in the body. Anywhere in the body. Excellent. But we're going to talk about which organ is most likely. So we'll go in descending order. The most important organ first, or the most likely organ first, second, third, fourth? Liver. Liver is first. Excellent. Liver is almost always involved. Liver. Skin. Very good. Skin. Pancreas. Very good. Lungs. Heart. Let's say adrenal first. Pituitary. And what else did you say? Kidney? Okay. Okay. The top three is most important one. The top three. You have to memorize the top three. The other ones are complications. You know, they occur later on. Okay, so top three, make sure you don't ignore them. Now, when you imagine if I put iron in if I cut your skin and I put a lot of pieces of iron, tiny pieces, what happens? It will cause trauma. It will cause irritation and inflammation and eventually cirrhosis, fibrosis, sclerosis. Okay, so it will go, first it will cause irritation, then acute inflammation. It will become chronic. It will be cool. And obviously chronic inflammatory tissue will be replaced by what? Scar tissue. Okay. So in liver it will cause cirrhosis. So it will cause liver, it will cause cirrhosis. Yeah, we'll come to that later. Yeah. Skin. In skin it will cause? Very good. So when iron deposits in your skin, it will give you brown pigmentation, golden brown pigmentation. Okay. Okay. So it's like a rusty color. Very good. Very good. Like an old car, rusty car. Very good. In pancreas. Now, in pancreas, it will replace which tissue first? Endocrine or exocrine? It affects endocrine first, but it can lead to exocrine as well. So it's not just diabetes. It can lead to diabetes. It can lead to hyperinsulinoma. Then that will be the opposite of diabetes. You know, it can lead to glucagon deficiency. So that will lead to what? Gluconeogenesis defect, right? Glycogen lysis defect. So it depends. Pancreas is a rich organ, has many functions. Essentially, let's say diabetes. Now, would this be diabetes 1 or 2? 1. Why 1? Good. So insulin is lacking, type 1, and it can lead eventually to chronic Pancreatitis, and essentially pancreatic insufficiency. So pancreas wouldn't be sufficient enough to do its job. Pancreatic failure. Okay? So chronic pancreatitis. Now look, hemochromatosis is not a joke. It's a systemic disease. You just have to be aware what I'm talking about. Any part of the body can be involved. But the top three are the most important.
The most vascular.
Lungs. What would it cause in lungs?
Cirrhosis.
Interstitial fibrosis. So memorize this term for now, and we'll go further in detail. It's a disease by itself. Interstitial fibrosis. I'm missing the S. Fibrosis. And heart, what would it do? Restrictive cardiomyopathy. I'll put RCM. Royal Canadian. What is that? Royal Canadian Mountain Police, right? RCM? Yeah, okay. Oh, I'm missing the P, yeah. So, restrictive cardiomyopathy. Restrictive cardiomyopathy. Write it down. Restrictive cardiomyopathy. Don't write mnemonics because you'll forget. Restrictive cardiomyopathy. Restrictive cardiomyopathy. Are you okay with that? Good. Cardio means heart. Myo means muscles. So the cardiac muscles become stiff. It's a cardiac muscle disease. Not valve. Not ischemia. It affects the cardiac muscle. Restrictive cardiomyopathy. Restrictive cardiomyopathy. And that's a disease by itself. Okay, so just for now, no. That's what we'll do. Adrenal gland. So it will lead to adrenal insufficiency. Adrenal insufficiency. What's Addison's? If there's too much depositions of iron in adrenal gland, what will happen to adrenal gland? It will go through irritation, inflammation, chronic inflammation, and fibrosis, and scar tissue. Is scar tissue functional? So what happens to adrenal gland? It fails. It stops working. Slowly, progressively. And what do you call that? Adrenal insufficiency. Adrenal is not sufficient enough to do its job. Adrenal insufficiency. He's giving me this serious look, so I'm like, let's make him smile. He's thinking about his adrenal gland and all that stuff. Oh my God. He's like,
I got this.
he's Caucasian, so. So Addison's disease is chronic adrenal failure, not acute. Addison disease, one of Addison's disease cause will be what? Hemochromatosis. It has many causes. The most common cause of Addison disease is actually autoimmune, but in this case, it's what? Iron overload. Okay. So Addison is adrenal cortical failure. Adrenal cortical failure. A for Addison, A for adrenal cortical failure. So write it down next to it. Adrenal cortical failure. Now, also write, so that's 1A. Adrenal cortical failure. That's A. Addison's A. Adrenal cortical failure. Good? Also write all cortical layers are destroyed in Addison's. All three layers. A for all three layers. All layers. All hormone deficiency. No. That's what I'm saying. Adrenal cortical insufficiency. I didn't say adrenal insufficiency. Adrenal cortical. Only the cortex. Okay. Glomerulosa, fasciculata, reticulata. Okay, so now if you don't want to know the name, think about it that the first layer produces aldosterone, second one cortisol, third one androgens. So all those hormones will be deficient. At the end of the day, androgens, cortisol, aldosterone deficiency. That's Addison's. Okay, pituitary. I mean, we have to go to endocrinology. So pituitary failure. Very good. And renal atrophy. At the end of the day, it leads to atrophy of all of these organs. Hemochromatosis leads to what? Fibrosis and atrophy of all of these organs. They shrink in size. They don't swell, they shrink. They go through atrophic inflammatory process. Okay, slowly become fibrotic. All right. Now, at the end of the day, what are we going to say? If somebody comes with hemochromatosis, you're going to pay attention to the skin. They should have brown pigmentation. On light skin, it's easier to see. On dark skin like mine, you might not be able to see it. So on light skin, it's very easy to see. Brown pigmentation. Plus, they might complain of what? Hyperglycemia and jaundice. And we're okay. Doesn't have to be always jaundice. Could be increased bleeding. You know about cirrhosis, right? It could be increased bleeding. It could be confusion. It could be ascites. It could be portal hypertension. So, as I said, everything that leads to cirrhosis, as long as no cirrhosis, you'll be fine.
But this is usually presenting later in life.
Yeah. In 45s, 40s, that age.
Time for the iron to build up.
Okay. Very good. The average age is about 40s. All right. Even though it's genetic disease, you know, yeah. It will become symptomatic when? Later on in life. Because it takes time, like you said. It takes time for iron to load and it gets deposited in the body over a long period of time. It doesn't happen overnight. Yes, sir.
Some of the symptoms that occur in childhood and early age.
Yeah. Now, if the problem was that there is an enzyme deficiency that you need for something, it would be immediate. Or if it was structural protein, it would be immediate. In this case, the problem is you deposit iron. It's almost like ants bringing iron depositing in your body. You cannot use it at the same rate as much as you deposit. So it takes a long time for it to deposit to the level that will cause damage. It's very slowly progressive.
Because you don't absorb that much iron to begin with.
Okay. Now, one more thing. If anybody tells me, I'll give you 5 points for Monday's exam, which is soon. What else could happen in these patients? What are they at risk of?
Risk of
It's a general question because now I'm asking you don't know what you're going to say. Yeah. Look, what kind of infection are they at risk of? How about that?
Iron digesting bacteria.
Iron digesting bacteria. Almost all bacteria requires iron for growth. So especially those bacteria that loves iron. I mean, in 20 days you will go to bacteriology, but you should remember, some of you should remember. Is there any bacteria, Mazen would know. He knows things in his sleep. Is there any bacteria whose name starts with something that has to do with the iron? Iron-loving bacteria. It always causes infection in children. Pneumonia.
Staph aureus.
Doesn't sound like iron.
It
Sounds like hemochromatosis. How about that? The bacteria sounds like this name. Haemophilus influenza. Excellent. No, not for that one. Not for that one. So Haemophilus influenza is most common, but again, that's mostly in children, but in adults, because this disease occurs in adults, there's one more bacteria. You guys mentioned the name today. Salmonella. Salmonella infections are predominantly increased in this age group. Okay, are we good? All right. So what are you going to remember, guys? This is what you need to remember. 3 things in terms of symptoms. For hemochromatosis, if it's based on symptoms, you're going to focus on what? Jaundice or liver cirrhotic symptoms, skin pigmentation or rash, skin problems, and diabetes. Okay, look for those 3. This combination always should make you think of what? Hemochromatosis, especially if the person is in their 40s and they're Caucasian. And especially if there's a family history. Oh my God, everything is making sense now. Alright, okay. So that's for hemochromatosis. Now, Wilson's disease is overload of copper overload of copper. Okay, you cannot use copper. You cannot use copper. So you can absorb it, you can store it, but you cannot use it. As a result, you keep storing, but you cannot use the stores. Now, in Wilson's disease, you have questions?
Yeah, before you move on to Wilson's, like, if management cirrhosis is causing fibrosis, why would you find hepatomegaly on visible exam?
Hepatomegaly in initial stages. Yeah, in initial stages, there will be inflammation, there will be infiltration of white blood cells and so forth, yeah. Okay. Anything else?
Isn't one of the management for it is to do regular blood draws?
We'll come back to management. Yeah, that's true. Okay, so I haven't gone to diagnosis and management. I'll compare them side by side so you can relate to them. Okay, let's go to Wilson's disease. Now, in Wilson's disease, coppers can deposit again anywhere in the body, but again there are some areas that are more likely. What does copper start with? C. So CNS. Oh, CNS. There you go, CNS. In this case, what are we going to choose? Cerebrum. Okay, cerebrum. And we will choose one more thing. Mr. Muhammad said it perfectly. What was that? Basal ganglia. Okay. Next thing is eye, cornea. Cornea of the eye. Doesn't have to be blue. You will get a ring in your eye, in the sclera of your eye. If you have brown eyes, it will be slightly different color of brown. If it's blue eye, it will be blue ring. If it's green, green ring. If it's yellow, yellow ring. So be careful. Don't always look for blue ring. The thing is, on the exam or on those things, the picture that I've taken is obviously from who? This disease common in which population? Caucasian, especially Europeans with blue eyes. So that's what most frequently will take that. But it's not. If it happens in a dark-eyed person, you will have a ring in the dark background.
What is that called again?
Kaeser-Fleischer ring.
It'd be darker usually?
No, the ring is actually lighter compared to the background, yeah. It wouldn't be clear-cut ring. It's just like,
It's a halo.
you know what? Have you guys seen the Northern Lights?
Yeah.
You know, like how it glows?
Yeah.
It looks actually beautiful. The ring makes you look beautiful.
No comment.
Yeah. Have you seen that National Geography, the Afghan girl on the cover? Yeah, the famous one. There you go. Pay attention to that. You will see the ring. Yeah. Okay. Now, cornea, basal ganglia, cerebrum, basal ganglia, cornea. These are the most important ones. Beyond that, what else could happen? What other parts of the body? What do you think? Liver. It has to come to liver because we're talking about GI. Good job. It has to come to liver, essentially. But in hemochromatosis, liver is 100% involved. Otherwise, it's symptomatic, at least for our purpose. In Wilson's disease, what's 100% involved? Brain. Brain, brain, brain. Okay? Then cornea, then liver. Anything else? Kidney, and then beyond that, those are extremely rare. So then kidney and skin, all things can be involved. But let's just restrict to this. That's enough. Remember, it's systemic disease. There's no limit on copper. It cannot deposit here, there, there. It can deposit anywhere. But some area requires more copper use. Like brain, the enzyme and the neurotransmitter release depends on it. In an eye and in liver. Liver because it specially stores it and metabolizes it. That's why. Okay. Now, in cerebrum, especially the frontal lobe. Especially the frontal lobe. You guys know frontal lobe are responsible for what? Judgment, personalities, and thinking. Exactly. So these people will have psychotic behavior, psychosis, schizophrenia. So they might have psychotic behavior. Aggressiveness, don't want to talk to people, they want to like to stay by themselves, they talk to themselves, they can hallucinate, they can have delusion. That's psychotic behavior. Okay?
Shifting behavior?
Yeah. Not necessarily, no. Shift in behavior will be mood swings. That's bipolar. Yeah, this is only aggressive mood, not depressed mood, excited mood. So when you talk about mood, you have depressive mood, which is depression, and mania, which is excessive mood, too much excitability. So that's sort of mania or psychotic behavior. Okay. Basal ganglia. In basal ganglia, please know that basal ganglia has many nuclei. Let me give you the names. Putamen, P-U-T-A-M-E-N, putamen. Huh? Globus pallidus, yeah? Quadrid nucleus, very good. Okay, putamen and caudate are the most important one. C-A-U-D-A-T-E. Okay, so those are two major ones. Now substantia nigra is not involved that much. Okay, substantia nigra is not involved, which is more midbrain. So basal ganglia, two nuclei of the basal ganglia primarily involved, putamen and caudate. Okay. Therefore, lesions or injury or trauma to those areas increases movement, uncontrollable movement. Uncontrollable movement. So not only these people will have psychotic behavior, they could also have uncontrollable hyperkinetic movement, too much movement that they cannot control. Huntington-like symptoms. Very good. Huntington-like symptoms. It can be Parkinson-like too. It can be Parkinson-like too. Yeah, it can be Parkinson-like too. Depending which nuclei are involved, most likely it's putamen and caudate, but it could, if it involves substantia nigra, it would be Parkinson-like. So it depends which nuclei is involved. Okay. All right. Cornea, it's nothing more than what? Just a ring. Okay. Liver, it will cause cirrhosis. In liver, it will cause cirrhosis. In liver, it will cause cirrhosis. So now the symptoms will be psychotic person. Okay. With chorea. Chorea comes from choreography, too much movement. You know when you choreography like dancing and stuff, it's movement, right? So that's why it's called chorea. It's abnormal movement, uncontrollable movement. You want to stop it, you can't. Okay. And then cirrhotic symptoms. That's Wilson's disease. Okay. Okay. Now let's move on to antitrypsin deficiency. In antitrypsin deficiency, you see, whenever we have inflammation or we have bacterial invasion, neutrophils, let me write it down for you, neutrophils are white blood cells. Neutrophils are white blood cells. They come from the family of granulocytes. Granulocytes. So they will have these granules in them. And the granules have these enzymes in them. They're filled with enzymes. And some of those enzymes are known as elastase and trypsin and lipase and so forth. Okay? But nonetheless, protease enzymes. So the granules of neutrophils stores what? Protease. What do protease do? They digest proteins. Liver is supposed to make antiprotease. What is antiprotease in this case? Antitrypsin. So when neutrophils wants to destroy bacteria and stuff like that, they will degranulate. They will do what? Degranulate. So they will release their enzyme. And they have to release this enzyme into tissue. That means they will digest the tissue plus the bacteria. And then from spreading too much, antitrypsin will come what? And it will deactivate these enzymes. Antitrypsin will deactivate neutrophil protease from causing damage to your tissue.
This is how an abscess is caused?
Okay, so now, abscesses are usually by different bacteria, so it depends. It could be caused in this case. Okay, so at the end of the day, that means if you don't have a inhibitory molecule to prevent damage being caused by these proteases, you're going to have more damage. You're at risk of damage, especially in two areas. So we're going to talk about those two areas. Now, lungs and liver. Especially two areas. Lungs and liver are affected. So it will cause in lung emphysema. In liver it will cause cirrhosis. So whenever you think of antitrypsin deficiency, you're going to think of two things. Emphysema and cirrhosis, hepatic cirrhosis.
This is more common in children.
Okay. Now let me give you something as a differential diagnosis of this. The differential of this could be a person who has COPD or they have hepatic cirrhosis. What's the most common cause of cirrhosis? What's the most common cause of cirrhosis? In this country, alcohol. In this country, alcohol. Do children drink? I hope not.
Hepatitis C.
Okay, so alcohol. Therefore, most people who have cirrhosis, they're over the age of what? 50. Alcoholics, long-term alcohol abuse. What's the most common cause of COPD? And emphysema is COPD, so let's just put emphysema. Smoke. Do children smoke? No, so most likely patients that have COPD are what age? Over age of 50. Okay? Now, when you see a child with emphysema and cirrhosis, you're not going to think of this. You're going to think of what? Antitrypsin deficiency. Okay? When you see a child, you know that this is genetic disease, not environmental, not acquired, not abuse of alcohol and smoke. Okay? Unless, you know, they're smoker from day one, by the age of 10, 13, they might have cirrhosis and emphysema too. Second-hand smoking, yeah. Yeah. And then second-hand drinking, sure.
Second-hand drinking.
Can that actually happen?
Huh?
Can that actually happen? Like breathing in like alcohol.
I don't know. People are crazy. You see people, you know what when they hear? This is why, and you know what? As a medical student, you have to be very careful not to make immediate conclusions. For example, when you learn something, especially psychiatry, when you learn something, a sentence that says, you know, people who want to, let's say, commit suicide, they will say something like that. And then I say something similar. It doesn't mean I'm going to commit suicide. Okay, so we have to be very careful. So there are parents, when they listen to TV, and they're saying, guess what? Red wine is good. White wine is good. This is good. And they start feeding their children. They will. And they have. And they get at the risk of this. And they do regularly. They think, you know, like, just like when you know aspirin is going to cure your pain or your fever, or antibiotic will cure some infection, and you think if you overdose it, they will be faster. So people do that, yeah. But unfortunate, right? That's why, you know, commercials, as I say, TV, usually these things mislead people a lot of time. Google, internet, and TV mislead a lot of people. You have to be careful as a student not to make this conclusion. Okay. Anyhow, so in this case, when the patient has emphysema will lead to exertional dyspnea. Write it down and I'll tell you what it means. Exertional dyspnea. Exertional dyspnea. Exertional dyspnea. Dyspnea means difficulty breathing. Difficulty breathing or shortness of breath. Same thing. Exertional means with activity or exercise. Okay, so that's what you will get from emphysema. Liver cirrhosis, you know the symptoms. You know the symptoms, so expect that. Okay, good. So we know exactly how to differentiate between them. Three major diseases. Three major, huge diseases. Let's go on to tests. What test would you do for hemochromatosis first? Let's do plasma test. Blood test or plasma test?
Check the hematocrit levels.
What would you see on plasma test?
Increase hematocrit.
Plasma iron will be increased, sure. Okay. Not so much in plasma, but it could be. Okay. Very good. Now, there's something called ferritin. What's ferritin?
It's the bound iron. Or it's not transparent, it's translucent.
Okay, give me the names first then.
There's transparent also.
Just want to make sure. Transparent, and then we write this down, and then you can think. TIBC. TIBC. These are something you should know. Okay. Iron is easy. Fe means iron. That's a symbol for it. Ferritin means storage form of iron. Ferritin is a protein. Ferritin is a protein that binds iron and stores it. Okay. Think of ferritin as a magnet. Magnet attracts what? Iron. So ferritin stores iron. Ferritin is iron binding protein. Iron binding protein where? In tissue, not in blood. Ferritin is not in blood. Okay, it's important that we know this.
Okay, so why you have it when you have like increasing iron absorption?
Why do you have increased iron absorption?
No, in the disease. It should be low, right, in the plasma test?
No. See, you have a GI problem. In the GI, you absorb too much iron. and then you take this iron and it's stored. Once it's stored, you cannot use it properly. There's overloading. The use is less, storing is more. So overall, you will store more. Does it make sense? It's almost like me eating. If I eat 24/7 and I don't exercise, what happens to me? Yeah, I'll get obese because I'm eating more than I'm using. In this case, iron is being stored more than it's being used. So overall, what happens to iron? It gets stored in the body. Okay. So, do you understand what is ferritin? Okay, ferritin is a iron binding protein. It's a storage form of iron. This ferritin is supposed to store iron. Transferrin. Transfer means transport. So it's still iron binding protein, but it's a plasma iron binding protein, not tissue. It transports iron. Transferrin transports iron. Are we good? Where? In plasma, in blood. Whereas ferritin is in tissue. Transferrin is in blood or plasma. Both are iron binding proteins.
Doesn't ferritin become active more when somebody has a bacteria infection?
Yeah, because bacteria uses iron. Yeah, good job. That's why I asked you when you were coming. You answered me now.
2 hours later, it's okay.
Yes, miss.
Ferritin is in the tissue. It's iron binding protein in the tissue. Then how do you find it in the plasma vessel?
It can leak to plasma. Yeah, it can leak to plasma. Yeah, but you will also find it on biopsy. We'll go there. Okay. Huh? Hemosiderin is a larger form of ferritin. A lot of ferritin will become hemosiderin. Okay, which is permanent tissue. You should never find that in plasma. Whereas ferritin can actually go between tissue and plasma. Whereas transferrin is only in plasma. Okay, so transferrin is only in plasma. Ferritin is from plasma to tissue, and then hemosiderin is only in tissue. Okay, all right. TIBC. TIBC stands for total iron binding capacity. Total iron binding capacity. Now, are we talking about ferritin or transferrin? Both, especially transferrin. So TIBC is a property of iron binding protein. It is a property of what? Iron binding protein. Iron binding protein. So if you have a lot of iron, what happens to iron binding capacity? Decreases, because most of these proteins are occupied or saturated. Saturation means occupation, like, you know, they're occupied, they're not empty. Look, if transferrin is empty and if ferritin is empty, its binding capacity is increased. It can bind more iron because it's empty. If it's full, its iron binding capacity goes down, decrease. Almost like the seats. If all the seats are occupied, there's no more seats available. So the binding or the seating capacity is decreased. There's no more room available. Okay. Alright, so in hemochromatosis, what happens to ferritin? Increase. Why? Because you're storing more iron. Good job. What happens to transferrin? Now transferrin number does not increase. Its saturation will increase. Remember that. So when you say transferrin's increase, it means transferrin saturation. Most of transferrin is occupied. It's not empty. Okay. What happens to TIBC? Decreased. Excellent. And this will be different for iron deficiency anemia. Iron deficiency will be the opposite of this. Okay, so make sure you understand. Okay, what else would you do? You want to biopsy right away?
No.
Okay. No, you're fine, you're fine. You can do biopsy.
You're scared.
Sorry.
You're scared.
She is a rebel, she never gets scared. I try to scare her, but she never gets scared. Yeah. Tell me. Biopsy. Huh?
Iron.
You'll find iron or ferritin, but mostly iron is enough because iron is easier to discover. Okay? And where would you do this biopsy from? Skin biopsy, please. Please, please, please. Skin biopsy. Skin biopsy. Okay. I know you will. Hoping that you will get some knowledge from someone's brain. Okay, so skin biopsy, that will confirm it. That'll confirm it. Okay, that'll confirm it. So, okay. Now, there was something known as hemosiderin, which is iron deposit in the skin or any other tissue. Okay. Hemocirrhosis means what?
Too much
Deposition of
Too much iron. Same thing as hemochromatosis. Good. Are we good with this? Do you need to do anything else to identify if this is hemochromatosis?
Yeah.
What else?
Hyperglycemia.
No. That's a complication of it.
I'm looking.
Yeah.
DNA test.
You can do DNA test. Excellent. You can do DNA test to see if the gene is deficient, partially complete, and so forth. You don't have to, but you will if you wanna. For the purpose of exam, you gotta know it. In real life, nobody does it. It's expensive. Biopsy is super straightforward and easy. How would you manage it?
Draw blood.
Phlebotomy, right? What is phlebotomy?
blood, like removing blood
From veins, not from arteries. That's why it's not arterotomy or arterectomy. It's phlebotomy from veins. Okay? And how do you do this? Regularly?
Yeah.
Yeah, unfortunately.
It's like every 2 weeks or something. Right?
What else would you do?
Decrease iron content in diet.
Okay, that's difficult. You can take, like things that are rich in iron, start taking those, like liver, like some vegetables that are rich in iron, like spinach and stuff. Maybe you have to decrease them in your diet. But what else would you do?
Oh, something that prevents iron absorption.
Iron magnet, an iron chelator or chelator. Yeah. What is that? No, what's the name of that?
Elation.
Differoxamine. Differoxamine. Okay, very good. Differoxamine. Ferrix is a name for iron. Ferrix, see, iron comes in ferrix. Also another name for iron is ferrix. D, without, removing. Differoxamine. Okay, will remove iron. That's the one. Differoxamine. Maybe the company names depend which company or which country.
Actually, chemistry is first, it was iron.
Yeah. Okay, we good? Let's move on to Wilson's disease. What would you do for Wilson's disease? What would you do first for testing? Blood test. Excellent. What would you find on blood test?
Increase copper.
Let's do something easier. Urine. Let's do urine first and then we'll do blood.
Increase copper in urine.
And copper, in urine, copper will be increased. Okay, increase urine copper. How about blood? You might not see increased copper, but you might. It's not a good test. Urine is good enough to screen. What else would you do?
Biopsy.
Biopsy. What biopsy would you do? Liver. In this case, fine needle aspiration of liver you would do. And what would you find? Copper deposit. Increased copper in liver. Okay. Yeah, CT. Yeah, CT would only tell you if there is organ degeneration. Maybe you can do CT of the head and you see putamen quadrate is degenerated, frontal lobe is affected, but it will not give you the diagnosis of Wilson's disease. Okay. You could do that. It doesn't really help. Yeah. Maybe you have to do genotyping, yeah, or genetic tests to see if, yeah. Okay, so how would you manage this?
Copper chelator.
Yeah. And the name of that is penicillamine. Penicillamine.
Would you also do serology?
Huh?
Would you also do serology and see lower decreased copper in plasma?
Yeah, so that's blood test, BA, not Bachelor of Science.
So you actually see a decrease?
Yeah, copper could be normal or decreased, yeah. Now there's the thing, and that's because copper transporter is defective to blood. You can keep it in tissue, you can secrete in urine, but you cannot keep it in blood. Okay, and that's known as ceruloplasmin. Ceruloplasmin.
That's the deficient enzyme.
Yeah, no, that's the copper transporter, ceruloplasmin. So now penicillamine is a copper chelator. Okay. Now CT scan. Those of you who want to CT scan, I'll come back to you, Muhammad. You can do CT scan. It will only show you atrophy of the quadrate and putamen and frontal lobe and things like that. It wouldn't help you in diagnosis. Okay. If you're asked, this person had, Parkinson-like or they had Huntington-like symptoms, what would you do? CT scan in those cases. to find the origin of symptoms. Otherwise, no. Okay, so you will do that. What else?
Increase copper in diet.
Yeah, essentially you can do that. You, for example, eat those diet that are poor in copper. You can do those. Replace them with copper-rich diet.
You don't
But
do
transplant.
Lobotomy?
Hmm?
Lobotomy.
No, it wouldn't help. Transplant. Transplant. Eventually you have to do transplant. Liver transplant.
Cirrhosis or the deficiency?
For both hemochromatosis and Wilson's. For both. Cirrhosis, yeah.
No, because of the cirrhosis.
Okay.
Can you modify diet?
Yeah. Yeah. Lifestyle modification diet, yeah, absolutely, yeah. Especially some fish, you know, fish and liver. People who eat a lot of liver, you know, you have to prevent those things. And but it doesn't really help. You can think about it, but yeah.
Ahmed is asking, why don't we give him bacteria to eat the copper and iron?
Yeah, you can give them bacteria. You know your body have more bacteria than your own cells,
No, I mean
but
inject them with bacteria.
yeah, that'll cause more infection. You see,
But doesn't your body also shed iron when you have an infection?
yeah.
I have an immune system.
So the thing is now, who is at risk? Hemochromatosis patient are at risk of infection, or copper patient? Or I mean Wilson's.
Hemochromatosis.
They're at risk of what?
Infection.
Infection. Which bacteria?
Salmonella.
Salmonella. And they will suffer from that. You have to treat them. So you don't introduce the same bacteria though. What food do you like?
Me?
Yeah.
Seafood.
Seafood.
Don't
If I
use-
take you to a sea restaurant, you know, if I open a sea restaurant, I shouldn't have you in charge of it. So you don't want to introduce bacteria to a copper restaurant, which is your body, in hemochromatosis or Wilson, I mean iron. So they will grow exponentially. If you introduce bacteria to a patient that has iron, too much iron, that's a happy day for them. Eid. They'll be celebrating. Or Christmas Day or Thanksgiving Day. They'll be, oh my God, crazy. Yeah, you don't want to do that.
Would you think induced stem cells would help?
Again, it's the same thing as transplant. So stem cells you have to grow. You know, what are you going to do with stem cells? You have to replace the liver.
Right.
So you have to remove the liver. It's the same thing, but that takes time. It's not helping. Stem cell will help with bone marrow, things like that, but not with liver. Yeah. Okay, antitrypsin deficiency, what test would you do first?
Serum analysis.
Do chest x-ray. Okay.
For this fibrosis.
Yeah, do chest x-ray. And then maybe you should do fine needle aspiration of the liver. Okay. So chest x-ray, what would you see?
Interstitial fibrosis. Emphysema.
How do you see emphysema on chest x-ray?
Expanded lungs.
Total lung capacity will be increased. Total lung capacity will be increased. Okay, but before that, you can do on physical exam. I'll put one. Let's say this is 2, this is 3. You can do spirometer, on which you can find that forced expiratory volume is decreased. Okay. Forced expiratory volume is decreased on spirometer. You can find one more thing, which I'm going to write in red. Make sure you memorize these things. Forced expiratory volume, 1 means in 1 second, over vital capacity is decreased. The ratio is decreased. Okay, so this ratio will be decreased. So FEV1 stands for forced expiratory volume. Forced expiratory volume. When you forcefully expirate, you take a deep breath and then you go. Okay, that's forced expiratory volume. And you blow that in this meter. A lot of physicians should have it in their office. And it will measure how much you can expirate in the first second, second, third. But the 1 stands for first second. How much air can you expirate forcefully in the first second? In normal people, it should be much higher. In emphysema patient, it should be less. They cannot expirate. It's obstructive disease. Obstructive disease. They cannot expirate properly.
The lung needs elasticity to contract.
Yeah. So think about emphysema this way. You can inhale air, no problem. But you cannot expirate it or exhale it. So over 10 years, you're inhaling and inhaling more and more, then expiring less. Overall, you will have what? Air trapping in your lungs.
Balloon.
Exactly. When air traps in your lungs, what happens to lungs? They'll expand. Your anterior posterior diameter will increase, and patient will have chest that is protruding, barrel chest, round chest rather than flat chest. Okay. So look for that. Now on spirometer, you will find that forced expiratory volume over vital capacity is decreased. The ratio VC, vital capacity. Vital capacity. Just memorize these for now, okay?
It's the same thing as colon.
Yeah, without the residual volume. Okay, vital capacity, okay? So this is decreased. Now on chest x-ray, how do you recognize total lung capacity? That means the lungs are expanded. The dark area is increased on x-ray. You see when you take chest x-ray, in the center of chest x-ray and slightly to the left you have the heart. On each side you have dark area, which is lung or air. The space between the heart and the right side, and the space between the edges of the left heart and the left side of the abdominal thoracic wall will be increased. Usually should be even. You know, if you take the diameter of the heart, the space on each side should be half of that. So that means the total space on each side should be half of the diameter of the heart. It's not true always. If a person is very tall, broad-chested, there's different. But overall, you can use that. If that distance between the heart, the margin of the heart and the thoracic wall is increased, that means the total lung capacity is increased. The chest has expanded. So that's one thing. Huh? No. No. I'm talking about the lung itself. The entire lung.
Pleural space, right?
Pleural space is only between the lungs and the thoracic wall. But I'm talking about from the heart into the thoracic wall. You cannot really see pleural space. Yeah. See, on x-rays, air appear as dark color. Tissue will appear slightly lighter color. So you cannot really see pleural space because it's also made of air. It will appear as one dark space. I'll show you some. So Friday we're starting review, right? I'll give you some x-rays. I mean, you have it in the book. You're responsible to look them up and come prepared. CT scan and so forth, and some slides, histological slides. I'll go over them. Okay. If not, Shukrullah will go over them, and Dr. Masab will go over them. All right. So that's one thing you will see. But you see, when you see lungs, when you guys see lungs on chest X-ray, the costophrenic angle, lungs, the dark areas you will see like this. And here you will see the heart. Okay. So if you see this, that means, look, the distance from here to here plus the distance from here to here would equal to the diameter of the heart. So obviously the distance on the left side will be lesser because the heart is on the left side more, right? Overall. Now, so that's one thing. So this space will appear dark. Let me just color it dark. Dark. On X-ray, the area where you have air, they will appear dark. The heart will appear slightly wider or less dark. Okay? The solid tissue will appear less dark. Air always appears dark, pitch dark. Now, in this case, that means if the lungs are filled with air, that means it will push on the diaphragm, correct? And the diaphragm will become more flat rather than dome shape. So you will see flattening of the diaphragm on X-ray. Look for that. So on chest X-ray, you will see total lung capacity that is increased. And flattening of the diaphragm. Flattening of the diaphragm, not dome shape anymore. It's very easy to see. Okay. Hopefully, I'll find a chest X-ray of emphysema compared to a normal person, and I'll ask you guys as a quiz on Friday. Okay.
The answer is emphysema.
All right. And how about this area? Look, this area. This is on the costophrenic angle. Okay, costophrenic angle. This angle will be also decreased. You will not have this angle. Imagine if let's make this darker. No, the angle will disappear. Yeah, the angle will increase. Yeah, the angle will increase. And where's the dark? There you go. So let's do this. This is what you should see. So this angle will disappear. It will become more flat.
The
The space will increase, but the angle will also increase, not decrease.
The angle, it means the angle of the lungs over the diaphragm. Not the...
This is 90 degrees, right? And this is 40 degrees. This is higher. And if it's this way, that's even higher. That's a larger angle. So it used to be like this, right? Used to be more acute. Used to be like this. Now it increases to this. So the angle increased, okay? Yeah. Okay, so the diaphragm will become flatter, the costophrenic angles will disappear. Okay, so look for those things. Look for those things. That's on this. On fine needle aspiration, you will see cirrhosis. You will see cirrhosis. Okay. What other tests would you do? Would you do anything else? Enzyme assay, of course. Look, if you just do chest X-ray and biopsy, it will only tell you cirrhosis and what? Emphysema. You should do biopsy of the lungs too. You will see fibrosis of lungs. But we don't know what's the exact cause of this condition unless we do enzyme assay or DNA test. And we find that antitrypsin is deficient. So at the end of the day, you have to do antitrypsin enzyme assay, and it will tell you antitrypsin activity is decreased. Antitrypsin activity is decreased, and that's confirming it. Okay. Now please understand, antitrypsin is an anti-protease. Okay. And now one more thing. There's two types of emphysema: smoke and antitrypsin deficiency emphysema, right? Genetic emphysema, acquired. Environmental, in genetic. Oh, where is it? This is environmental. Yeah. Environmental or lifestyle, and this is genetic or familial in families, right? So understand those concepts too. But there's one more thing I want to say. When you smoke, the smoke mostly go to the higher lobes of the lungs or lower lobes? Higher lobes. So in smoke, these areas are affected first. So it's upper lobe emphysema in smokes. In smoke, upper lobe emphysema occurs first. Are we good? Now, antitrypsin is carried by what? By blood. It's an enzyme. Blood goes where mostly? Lower areas. So antitrypsin emphysema will occur mostly in the lower lobes. So just because if I mention, you found emphysema tissue or bubbles or something like that, or increased air trapping. Look, if I say air trapping, that's the same thing as emphysema. In emphysema, air traps in lungs. You cannot exhale air. You cannot get rid of air. So if I say air trapping is more pronounced in the lower lobes, what are you going to think? Antitrypsin. If I say air is trapped more in the upper lobes, smoke induced. And of course, the age will help you too. So, all right, there you go.
What's the name?
You really can't do anything. Yeah, you just have to do symptomatic treatment. Make sure they don't smoke. Make sure they don't do argila. Make sure they don't do secondhand smoking. All of that stuff. Yeah. And don't drink.
This happens. So this is like midlife.
Did you hear that?